And Alex, I'm ready to turn it over to you.
Awesome. Thanks so much, Susan. Hello, everyone. Happy to be here today. I have some exciting, hopefully exciting, announcements related to our CHW, CHR program and the work that we're doing in this space. So I will be going over a pretty, I would say, detailed presentation, but I'm going to be going over it at kind of a rapid pace to make sure we have enough time for discussion. I think probably what we'll need to do after this initial presentation is schedule some time on an ad hoc basis to have an additional forum once we kind of get an understanding from you all on where the existing confusion and pain points might be with some of this content, but did want to unveil this here and provide at least some time for discussion and dialogue. So again, my name is Alex Demian. I'm an assistant director here with Access in our division of community advocacy and intergovernmental relations. So but for those of you that haven't worked with me yet, there's probably not too many of you out there at this point, but I'm happy to be here. And if we go ahead and go to the next slide, I'm just going to dive right in. So I think a lot of folks on the line are probably pretty familiar with what a CHW or a CHR is. For purposes of this presentation, I'm really going to be using the CHW terminology as kind of an umbrella term for a few different provider and professionals in our communities. So community health workers, community health representatives, we have our promotores as well. So there's, and I know there's a lot of additional kind of community specific terminologies that are used out there, but for purposes of this discussion, just to streamline everything, we'll really be using that CHW terminology here. But it is broadly applicable. And for those that don't know kind of what this group of professionals, of individuals are, really they're frontline public health workers who are trusted members of the community. And usually they're from that community, right? So they have a really in-depth knowledge of how the community works, the language that's used, the dialect that's used, the do's and don'ts of how to communicate within that community. And really they're a pretty unique and kind of individual practitioner in these communities, in that they help individuals navigate the healthcare system. They encourage preventative care and kind of give the reasoning behind some preventative care that folks might not always engage in, help to manage chronic illnesses, maintain healthy lifestyles. And then really, I think one of the more critical things that they're able to do is kind of translate the jargon that we use in healthcare into a way that's digestible for the communities that they serve and that they live in. So really kind of explaining the whys behind some of these things and in a way that will land with their community. If we go to the next slide. So historically, these practitioners have not been eligible for Medicaid compensation, right? You can bill Medicaid for the services delivered by these individual practitioners. However, CHWs have been and CHRs have been around for a long time in Arizona. There's a long-standing workforce that have been around for decades. That have largely been funded by grant or local or tribal funds. So they've been really community specific and program specific historically, but they have been a critical part of our delivery system for a long time. We have at least 5 of our contracted health plans or our managed care organizations that we know utilize CHWs to assist with things like care coordination, etc. They've done so through the use of their administrative dollars. So again, they've not been able to directly bill for services provided by CHWs. And then also 19 of the 22 tribes, at least that we know of, are using CHWs or CHRs in Arizona. And those have been, again, longstanding programs within the tribal communities. Usually they've been funded historically through some IHS dollars. And they make up a pretty significant percentage of the overall CHW workforce. So there's definitely an outsized impact with our tribal communities when it comes to these types of professionals. Next slide, please. So historically, we haven't been able to reimburse CHWs. And part of the reason behind that is because there's never been kind of a license or a certification that has existed for CHWs within Arizona. That changed in 2022. Actually, a couple years before that, the Arizona legislature passed and then the governor signed into law bill that required our partners at the Department of Health Services to promulgate some rules that developed what's called a voluntary certification for community health workers. That took a couple years, but we were really excited to partner throughout that time with the CHW community as well as ADHS to get a rule that is and a voluntary certification that worked for the CHWs in the community. It worked for us. And it was a really kind of comprehensive rule that ultimately went into effect late in 2022, so November 26th, November 6th, excuse me, of 2022. And they began accepting applications for the voluntary certification the very next day. So it's been it's been a little while, right, since this has been live. And if we go to the next slide, this is what really allowed for us to have kind of the first domino to fall on our road towards Medicaid reimbursement for CHW. So once we had that voluntary certification, we had what we needed to go to our federal partners and say, hey, we have this kind of new certification that exists. We can guarantee that everyone that we reimburse for meets these minimum, reimbursed for specific services, I guess we'll get into that in a moment, but meets these minimum requirements. So, please let us start to pay for community health workers in our delivery system. In order to do that, as you see on the screen, we had to submit what's called a state plan amendment. So for those that might not be familiar, Medicaid is a state-federal partnership. And really that is, I think, especially important as it relates to how Medicaid's financed. So if we want to make a change to our program and use federal dollars to help support that change, we have to get agreement from the federal government, which is what we did through the state plan amendment. So we submitted that. And if we go to the next slide, this is kind of the timeline that we took. We submitted it in late 2022, like right after the voluntary rules were finalized. And then in early 2023, we actually received approval for that state plan amendment. So that really allowed for us to have that second domino fall to say, the federal government agrees, we agree, now we can move towards implementation. If we go to the next slide, we'll get into a little bit about what that means. So we did a lot of research into other states that had done this and kind of really dug into the decisions that they made around what services they were able to reimburse for and kind of what limitations they had on their services. So we really took kind of the data that we were able to gain from their experience and applied it to our program as we kind of entered into our early implementation phase here in Arizona. So there's 3 codes really that CHWs can bill for here in Arizona, and really they revolve around the education and training and preventative services that are delivered to members. There's a couple of different codes here. Really, the difference is whether you're providing these services to one member, to a few members, or to a larger group of patients. I think what's important here, and again, I think we'll get into this in a little bit of additional detail in a moment, but we know that CHWs do a lot more than we can reimburse for. We fully recognize that, but there's kind of a Venn diagram of what all the things that CHWs can do and then what Medicaid can reimburse for. So we were really focused on that middle part and figuring out kind of what that overlap was, because we know that there's going to continue to be a lot of stuff that CHWs do to improve their communities, to advocate on behalf of their communities, et cetera. But there's this really important overlap and kind of now financial incentive for CHWs, CHW organizations, providers to deliver these services and reimburse for them, or seek reimbursement for them through Medicaid. Another note here, just on the service codes, we did implement some kind of billing limitations to make sure that we're able to monitor utilization, especially in the early phases of implementation of this benefit. So we have a maximum of 4 units per day, up to 6 units per month per member that can be claimed. And then if folks need more services than that for some reason, we are allowed to go above those limits. It would be subject to a prior authorization process if there's a medical necessity or a medically necessary reason to go above and beyond those limits. Next slide, please. So again, that Venn diagram. CHWs can still perform the full scope of practice as specified in this citation. Really just refers you to the voluntary certification rules, which details the scope of practice for CHWs, and technically it's a voluntary certification. So a CHW doesn't even need to be certified in order to continue practicing in the community in the same way that like a nurse would have to be licensed in order to practice, right? So that's the beauty of the voluntary certification for community practice. However, if a organization or a CHW wanted to be involved in Medicaid billing, that voluntary certification is a mandatory prerequisite for Medicaid reimbursement. So that's how that certification is how we guarantee the federal government that all CHWs operating in our delivery system are availing themselves of Medicaid dollars are meeting a certain minimum standard of requirements. So when serving Medicaid members, CHW services have to be medically necessary. They have to be recommended by a physician or another licensed practitioner, which really just means you need a referral, right? If a licensed practitioner sees the need for CHW services, they're going to send a referral. And that has to be kept on file to indicate that medical necessity criteria. And then the certified CHR or CHW must work under the direction of an access registered provider. And we'll get into kind of what that means here in a second. So if we go to the next slide, we set up two pathways for reimbursement, kind of to that last point in the previous slide. So the way we had to set this up is that the CHWs aren't individually registered with Access, but they're employed by an Access registered provider. So there's two ways we could go about that, right? One was a little bit more straightforward for us. So we knew that we were going to have to take a two-phase approach, and we didn't want to delay this first phase for the sake of waiting for phase two. And a little bit peek under the hood, phase two is what I'm excited to talk about today. That's what we have going live. So I think most people on the line involved in this have been kind of familiar with phase one, which allows for currently Access registered providers to employ CHWs and bill for those services as appropriate, right? So what that looks like is the CHR or CHW would need that certification. They would be employed by a clinic or another existing access provider type that's enrolled with us. And then the CHW would deliver the service under that provider type. That provider would submit a claim, and then the claim would be paid as long as all of the other requirements are made, right? Medical necessity, et cetera. So we were excited about that because that opened the door a little bit to existing providers employing CHWs, or if they were already employing CHWs, kind of flipping the fund source to what's paying for those hours, right? And then that frees up other dollars, grant dollars or administrative dollars that might have been going to the CHWs to be used for other programming. Phase two was kind of the bigger lift for us. So what we didn't want was we knew that a lot of the CHWs in the community were employed by localities or community-based organizations that maybe weren't providers and haven't historically been involved in the Medicaid space. So we didn't want to create a barrier for and only allow for Medicaid kind of historically medical or behavioral health providers to be the only ones that could avail themselves of this opportunity. So we wanted to set up a provider type to allow for those localities and to allow for those community-based organizations to come into our delivery system and ultimately deliver Medicaid compensable services. So we had to set up a new provider type to do that, which is now live, and I'll get into the details in a moment. But we're calling it a CHW provider. CHW organization is the name of the provider type. And what it'll look like there is that organization will enroll with Access as the Access registered provider and meet all the criteria that I'll go through in a moment. That organization would employ the individually certified CHWs. And then they would, the CHW would deliver the service. They would utilize the CHW organization provider that they work for to deliver the claim, submit the claim to Access. The medical necessity criteria, all of that still applies. And then once that claim is submitted to Access and approved, Medicaid reimbursement would flow from Access or the health plans to that organization. So really what this allows for is a kind of creative pathway for those community-based organizations and localities to come on board and deliver services to our Access beneficiaries. Next slide, please. So for phase one, just really quick, I won't go through all of these, but this is the list of existing providers that we open CHW reimbursement for. So these providers can employ CHWs and bill directly for their services under the existing Access enrollment or provider type that you all have live in the system with us today, or any future providers that like to come on board. All providers must have a COS of 01 in their provider profile to bill for CHW services. That was kind of one of the limitations of the code that we chose, is it had to have that kind of place of service or COS in their profile to allow for that billing. However, if there's other provider types that would like to employ CHWs and bill for those services, there is an opportunity for other types of providers to enroll as a CHW organization with us and kind of carry two enrollments with the agency. And, you know, when you're delivering your normal book of business, you would, you know, bill under your existing provider type. And when you're delivering CHW services, you would kind of put that provider type's hat on, right? And submit the claims under that provider type. So there is that ability for other providers to come on board and bill for these services. It's just, there's kind of that additional hoop to jump through the way that we had to set this up. Next slide, please. All righty. So roles and responsibilities, I hit on a lot of these already. I won't go too deep into the weeds here, but when the employer is registered, right, when the organization is registered with Access, whether they're a historically existing provider or a new provider, it must ensure that, again, all CHWs and CHRs are certified, have that voluntary certification. That is a mandatory requirement of this program. The employer can submit claims using the allowable codes for covered services, and the employer must maintain accurate and current records of the CHW certification and other documentation that might be necessary, right, to maintain if there was ever like an audit or something like that, right? We want to make sure that we're maintaining the referrals on file, the diagnoses that are being treated, right? All of the things that would generally be kept on file for delivery of a medically necessary service. Again, providers still are welcome to employ and work with CHWs who are not certified, but you will not be able to bill for services delivered by those CHRs or CHWs if they do not have the voluntary certification. So we don't want this to kind of be construed as something that's a requirement for CHWs to have during their community practice. If they're not interested in getting the voluntary certification, that is absolutely okay, and they can continue doing their work. That work just cannot be funded by Medicaid dollars. Next slide, please. So phase two. Now here's the good stuff. So as of, if you haven't heard already, as of March 4th, we established that new provider type. Again, we're calling it the CHW organization provider type. It is currently live in our system, so we are able to accept applications. I think we've gotten 1 or 2 so far. So we're really interested to see how the process kind of plays out for those early adopters. And then, hopefully this presentation provides some helpful detail. It allows for CBOs, localities, tribal organizations, and other institutions employing those CHWs to come on board and bill Medicaid. Existing providers, again, that were not included on that list can still enroll as this new, that previous list for phase 1 can still come on board and enroll as a CHW organization and carry those 2 provider types. And then lastly, the CHW organization provider type is considered a high-risk provider, and I'm sure the first question for you all is, what does that mean? So if we go to the next slide, we'll get into kind of what the requirements are. And really, this is just a risk designation in our system, and risk might be too strong of a word, but it kind of defines the different risk categories, define the requirements for enrolling essentially. So really what a high risk provider has to do, what this means for any provider categorized as high risk means you have to submit an application through our provider enrollment portal, which every provider has to do. You have to complete a fingerprint-based criminal background check. You have to complete a site visit. And then this is specific to the CHW organizations, obviously, but you'd have to submit the list of certified CHWs or CHRs that will be billing under you. And then that'll continue to be a requirement as you bring on new providers. So I think that's the one big caveat and difference between CHW organizations and other kinds of providers in this category. But lastly, there's an enrollment fee, which is pretty standard as well. And a line of sight, I mean, this can ebb and flow, but basically folks and organizations should anticipate this taking about 60 to 90 days. So a couple months from initial application is when you can expect to get the results from that application. Next slide, please. So where do you register? So the APEP portal, this is our online provider enrollment portal, can be found at the link on the screen, and folks will have access to these slides. So if there's any questions like that in the chat, we'll make sure that these get to folks, and we'll make sure also to drop all relevant links in the chat here for you today. But did want folks to know that you don't have to write down all of the www dots or anything like that on the screen. We'll send them out. You're going to click the user registration button to begin the registration process, and then the portal's pretty intuitive. We get a few questions here and there, but for the most part, we have training materials embedded within that and online as well. So it is pretty intuitive. If we go to the next slide, we got a little bit of additional detail that we can provide here, but outside of this level of detail, I mean, it's really pretty much on a case-by-case basis, depending on what issue you're running into. So you can always reach out to myself or others on the line if you have really specific questions that come up through the process. But as a little bit of a line of sight into what you can expect and what's going to be required through APEP. So basic provider information, your entity name, correspondence information, who's your point of contact, tax ID, location, address, billing associations, etc. You're going to have to provide ownership disclosures to help us with those background checks, etc., which includes disclosures of ownership and control interests, as well as any adverse actions the applying individuals might have, felonies, state exclusions, terminations, other actions. If you don't submit these, we will find them. So please, when you're in that disclosure portion of the application, disclose anything. It's not going to necessarily exclude you. I won't say that categorically. It might, right? In certain instances, but if you don't disclose them, we will find it as part of that background check. So better to err on the side of providing more information as opposed to less, which will help in turn expedite the process, right? So that there's not as much back and forth through the process. So next, employee details. This application step has an Excel spreadsheet that you'll be brought to in the portal. Appropriate information will have to be included and uploaded. The CHW staff that you'll be employing will be critical there. Make sure that you're filling out all the details, making sure that document is complete. Again, that'll reduce the amount of back and forth that we'll have to go through between your administrative staff and our provider enrollment staff. And then there's going to be a bunch of uploads that you'll have to meet as well. W-9 tax identification, CHW certifications, etc. This is really just a summary, high level of what to expect. Again, I think each individual organization is going to have a little bit kind of different complexities, right? Each organization is a little bit different, so there's going to be kind of different questions that come as a part of each individual application. So we just wanted to give you kind of a flavor of the overall view of what's going to be required. Next slide, please. So once the application is submitted, reviewed, approved, then what happens? So this is kind of the next step. Once you have that access enrollment and approved and in hand, and your access ID provider ID number will be issued, Once that happens, it's important to remember that about 90% of our membership here in Arizona in Medicaid are enrolled in managed care plans. So we're a mandatory managed care state. We have a small fee-for-service carve-out for our American Indian Alaska Native population, but most of our members in the community are going to be, aside from our tribal members, that's a big important caveat I think I want to reiterate and emphasize. But outside of that population, most of our members are managed care. So it's going to be important that folks remember that once you get that access registration, you're still going to have to become a part of the managed care organization's network that you would like to work with. So we have about 7 or so companies across the state with multiple lines of business within some of those companies. We have an entire list of the health plans on the bottom of this slide if you're interested. Which has all of the contact information that you can utilize to get in touch with their provider enrollment departments, respectively. But it's important that, if you're in this, Central Valley and you want to work with Mercy Care as an example, that you credential with that health plan and the others that you would like to do business with, depending on your interests. So that's important. You have to reach out to them individually to start that process, to initiate that process, to become a recognized provider within their network. And then once you're approved and contracted with the health plan and within their network, you'll have to work with their billing department for appropriate billing practices. So they're all going to be a little bit different, but largely they're pretty much the same. But we don't have really line of sight into those kind of complexities from our perspective. So again, that's going to be kind of a conversation between your all's administrative staff and the health plans. Next slide, please. For fee for service, so for that other about 10% of our population or so, give or take, maybe a couple percentage points, once the enrollment processes have been completed with access registered CHW organizations that are serving our fee-for-service members. So really that's going to be our American Indian Health Program members. If you're serving a member that's enrolled with our American Indian Health Program, you may bill us directly. That's the only instance where really, for the most part, that you would be billing access directly for services, medically necessary services. That guidance can be found at the links here on the screen, and we'll make sure to drop those in the chat as well. But we have a really comprehensive billing manual that'll walk you through kind of all of those requirements at a high level that apply to all provider types within our system. And then we have some language in there as well that's specific to the CHW organization provider type and some of the complexities that might exist there. So I think I took too much time for that, but we really wanted to give you kind of a comprehensive overview so that you all can at least start generating some questions on what still doesn't make sense and what questions you might have. I've seen some activity in the chat, but I know that we're right at the half hour. So Susan, if we want to maybe take a question or two, I think the next slide is just a question slide if we go to the next slide, but we'll defer to you on exactly how much time we have.
Sure, Alex. Let me just give you a couple of questions that I've seen in chat. One is, do behavioral health therapeutic homes, CHWs, fall into this?
Behavioral health therapeutic homes. So yeah, so it really, I think, comes down to the provider type that you're enrolled as, right? So as an example, if you're an SMI clinic or a behavioral health home, and you're enrolled as an integrated clinic, as an example, you can bill under that provider type. If you go back, we'll send the slides out so that we don't have to jump around here, but that slide that says the list of eligible providers for phase 1, those are the providers that can bill for CHWs directly, right? If you're not on that list and you are still interested in employing CHWs and billing for them, you will have to go through the phase 2 process and become a CHW organization and enroll as that provider type for those services that you're delivering.
Alex, I think you answered a few comments just with that, because people are asking if they weren't on that list, how would they get on that list? And then I did also see a question, would this be appropriate for Indian Health Services facilities?
Sorry, can you repeat that, Susan?
Yeah, sure. It's, would this be appropriate for Indian Health Service facilities?
So it depends. IHS facilities are going to be registered already, likely as one of the existing provider types, right? So probably you're good to start billing for CHW services. I think an important complexity within the IHS delivery system is that CHW services do not qualify as a facility visit. They're considered what's called incident to a facility visit, which means the AIR cannot be billed for these services, but you can bill the fee for service rate for these services. So want to mention that, but likely if you're an existing IHS facility, you're probably enrolled as one of the phase one providers and can bill under that under that enrollment and license, I guess, as applicable. But definitely do your homework there. Make sure you're enrolled as one of the eligible phase one providers. If you're not, then you would go under phase two. So that's kind of how the algorithm would work there.